Thanks. Hi, I'm Peter from the Epidemic Diseases Research Group. So we just thought we would try and keep people updated on current themes. So I thought I'd give a quick update on Zika virus, because you may have heard about this in the news a lot. So I'll just quickly go through what it is and what's the current epidemiology and why we're worried about it and what the next steps are in a very generic way. So it's an RNA virus, it's a flavivirus, and there's two genotypes, African and Asian, and I'll talk a bit about the epidemiology later. And that's just the structure of it. It was first identified in monkeys in 1947. So this just came, they were doing yellow fever surveillance in the Zika forest in Uganda, and they identified this new virus. And it wasn't until 1954 they found the first clinical case, the first human was infected. In between they'd done some serological surveys and found serology positive humans, but there'd been no disease. And during an outbreak again of what they thought was probably yellow fever, they identified some human infections. So it's been around a long time, but hasn't hit the news until very recently. So it's an arthropod, which is insects and other arthropod, like spiders and things. It's borne virus. It's the same group as dengue, yellow fever, chikungunya, Japanese encephalitis, West Nile virus, and other flaviviruses that are transmitted by mosquitoes. And it's been isolated from a type of mosquito called the Aedes genus. Aedes aegypti, the first one in that list, is the most important vector in this group, and we'll talk a bit more about that later. And it's thought to be transmitted primarily, it's the females that bite, and it's primarily thought to be the Aegypti Aedes mosquito that's transmitting it, but that's still not entirely sure. The problem with this mosquito is it's very widespread, and it's an urban mosquito, and it's day biting. It bites the 2 hours around dawn and dusk, so it's difficult to avoid being bitten. So this is the Aedes aegypti mosquito. It's got this typical white lyre shape on the thorax at the top, and this is the distribution of it. And you'll see this is the worry. It's extensively present across the whole of the tropics, including in the south of the US. So the population at risk going across South America, Africa, India, Asia and the bottom of China is absolutely enormous. So this is one of the reasons it's a worrying virus. But perhaps I'll talk a bit about one of the other Aedes mosquitoes, Aedes albopictus, which is a more cold-tolerant virus. And this is an issue because this mosquito is actually present in southern Europe. And there is some evidence that this may also be contributing to transmission. So there was an outbreak of of an illness in Gabon, and they did some surveillance in mosquitoes and humans, and they found that the Aedes albopictus mosquito was infected with Zika virus. And there's been some vector competence studies done in Singapore here at the bottom. It's only a small sample size, but they tried to infect 12 Aedes albopictus. And by day 14, 100% were infected and were excreting the virus in their salivary glands, so they're indicating that they not only get infected, but they can transmit the virus. So this is an issue because this is a colder tolerant mosquito. So it's got wider boundaries than Aedes aegypti. So you can see it goes much further up into the US and even goes into southern Europe. So they've got these mosquitoes in Spain, Italy, and across the Balkan Peninsula. We don't yet know how efficient this mosquito is at transmitting Zika, but it's a potential threat now, not just in the tropics, but also in the margins and the bottom of the temperate regions. So it might be a risk also for southern US and southern Europe. Just quickly to go through the spread of this virus. So, as you know, as I just said, it was 1947 it was first identified, and then not a lot has happened for many decades. It's been sporadically detected through sero surveys, very little clinical evidence of illness in Africa, but when people look hard for it, they have found it. Then it was detected in Asia, but again, some sero surveys, a few clinical examples, but really not thought to be a significant pathogen. Detected more widely across Asia, probably it may have been there a long time. This was just an ascertainment bias when people start looking for things and the lab capabilities are there. But then in 2007, this is where it really started to suddenly pick up after decades of it being thought of a sort of an uninteresting novel virus. There was a big outbreak in Yap Island in the Pacific in 2007, with very high infection rates. And then in 2013, it spread to French Polynesia, again a very big outbreak. And then Easter Island in Chile, so we don't know which way it went, but either went that way or the other way, but it'll be humans that are spreading this, not the mosquitoes. They can only fly a few hundred meters, so this is infected humans are travelling between countries and getting bitten. And then it entered South America, and it really blew up in South America last year. Why it took so long, from 1947 to 2007, before it really exploded, I think remains a mystery, really. It may be due to competition between different flaviviruses and cross-immunity in different areas. I don't know, but there's plenty of dengue in Asia, so it's hard to explain at the moment. And then it's just continued to spread. This is the distribution in May 2015. So in early 2015, it was first identified in Brazil. By October, November, December, January, so it's spread across large parts of the Americas now. I think this is a little bit out of date, but I think there's now 27 countries in the Americas that have got Zika transmission occurring in the country. So why are we worried about it? Well, we weren't that worried about it. The clinical presentation has generally been quite mild. Based on sero surveys, it's thought that only about 20 to 40% of people who are infected actually have symptoms and come to the doctor. The rest have either a subclinical or an asymptomatic infection. And those that do come have a fairly mild illness. It's a bit like dengue, but probably a bit milder. They get a rash, fever, joint pains, sometimes conjunctivitis, headache, things like that. Incubation period is probably somewhere between 3 days and 2 weeks, variable. The illness probably lasts, 5 days to a week, and then spontaneous recovery. And this is the rash, so quite a florid rash. But it wasn't thought to be a big problem, but then other issues have started to arise. So one is other routes of transmission. I'll just go through those. One is transfusion. That's not surprising. We know that people are viremic, and if you transfuse viremic blood into other people, you're going to probably infect them. So given the very high attack rates, though, and the asymptomatic infection rates, then there's a risk of a reasonable prevalence in the blood donors. So this was a study done in French Polynesia where they showed that about 3% of blood donors were PCR positive for Zika virus in the blood. So this is a problem now. You've got to think about either decontaminating the blood or excluding people who've travelled to Zika virus areas, and I believe the UK government has just announced that they want to exclude people who've been to Zika areas from giving blood for a certain time period. Then there's sexual transmission, which always excites the press, even though it's probably not a very important transmission route. Compared to the mosquitoes, this is going to be not a significant transmission route, but it certainly is, a public health issue because of how do you give advice how to avoid it. Not entirely unexpected. So back in 2011, there was a report of sexual transmission occurring in the US. So this was 2 American scientists. One of whom was the first author, so he published himself. One way to advance your career is infect yourself with the novel virus, and your wife. So he was working in Senegal, and he went back back home. His wife got infected and got Zika virus, and she'd never left Colorado. So it wasn't proven, but it was thought that the probable transmission route was sexual. There were other people in the household, his children, and there was no evidence of them getting infected, but his wife was probably infected sexually. More evidence. So this is from the 2013 outbreak in French Polynesia. So a man came with blood in his semen, and they isolated live virus, not just PCR positive, but they could culture the virus from his semen. And then you've probably all heard about this. This is this is the thing that got in the news. Probably sexual transmission in Dallas. Again, it would have been a traveller returning and infecting someone. Given that it's not going to be a chain of transmission, it's going to be just partner to partner once transmission. Probably it's unlikely to be a significant factor in the disease, but it gives big problems about what do you advise people when they've been to the Olympics in South America, about coming back. But given that 60 to 80% of people are asymptomatically infected, we don't know if then that would still lead to possible infectious semen. And if you've had a rash, it could be dengue, it could have been Zika. What do you do, and how long would you have to use condoms for? We just don't know that at the moment. The bigger risk probably is sexual transmission whilst trying to get pregnant. We'll talk about that later, and the risk to fetuses. So there's also perinatal transmission. So perinatal is a bit different from congenital. So perinatal is more about during delivery, as well as whilst the fetus is gestating. So there's a couple of reports where it looks like the infant was infected during the delivery or shortly afterwards, because the child actually got sick and got a fever and got a rash, and the women had a rash just around the time of delivery. So there seems there's a possibility of perinatal transmission to the child, but then that's not too worrying because the child is fully formed and it just gets an illness, it doesn't get any developmental abnormalities. The big issue is congenital infection, so infection during gestation, which is causing developmental problems in the children. And this is why WHO announced a public health emergency. It's not because of Zika spreading around the world. It's a fairly mild, not a great, public health problem in terms of the long-term impact. But this is the real issue. There's been an increase in the number of children identified with congenital abnormalities, developmental abnormalities. So microcephaly, it's an indication of that the brain has not developed properly. So it's the brain swelling that causes the skull to get to the right size. And so if the nervous system doesn't develop properly, the skull doesn't develop the full size. They also have excess skin because that continues to grow, but not the skull. And there's various definitions of it. And I think this is one of the problems. The definition is not that well agreed. So people are either using head circumference that's less than the third centile, or less than more than 2 standard deviations, or more than 3 standard deviations from the mean after adjusting for sex, age at delivery, and gestational age. And so different definitions have been used. And if you get the gestation wrong, then your definition of microcephaly is wrong. So this is one of the challenges about making the definition of microcephaly cases. And so this was not identified as a problem until in October, when 26 cases of microcephaly were reported from one region in northeast Brazil. And then the Ministry of Health in Brazil did a further investigation, and they announced a public health emergency nationally in November. And this just shows where the microcephaly cases are located. And so this is the numbers of microcephaly cases 2010, 2014, and this is 2015, 16. So you can see a massive difference, particularly up in this northeast area. And they've had a 20-fold increase in the number of cases of microcephaly reported from some areas. It's difficult because actually beforehand they were underreporting. So the rate of microcephaly in Brazil before in 2010-14 was lower than the US, and that's probably underreporting. And now people are looking harder, so they're finding more. How much of it is attributable to Zika, we don't know. They've already done some studies where they've looked at a cohort of several hundred, and they've only actually confirmed 40% actually have got microcephaly. They've been misdiagnosed because they got the measurements wrong or the gestation wrong. So there's still a lot of uncertainty about the scale of the problem. But there's certainly good evidence that there is a problem. But I think we'll probably end up finding that the scale is less than what's currently reported. So this is that one region on the northeast tip, Pernambuco. So this is the numbers of microcephaly cases reported, and you can see there's just a massive increase in that state. And it's temporarily associated with the Zika virus transmission and pregnancy. So this is in the state of Pernambuco. They had an outbreak of fever and rash. They didn't really identify it as Zika until here. This was at the end of last year. They saw the increase in cases of microcephaly, and it's 9 months after the first trimester. That was during the peak Zika transmission. There's the Brazilians Medical Genetics Society have set up a Zika embryopathy task force where they've been reviewing these cases. As I say, they've reviewed a bunch. They're not all microcephaly, and the ones that are, they're looking into those. So they've looked so far in this publication, they looked at, I think, 35 or something cases. The majority of the women had a rash in the first trimester, 57%, or a rash during the pregnancy. And this just shows other neurological abnormalities. So it's not just the small head, they have developmental and other neurological problems. So far they've tested all these children for the normal infections that are associated with microcephaly, like rubella and CMV and toxo and stuff, and they're negative for all of those, and they still haven't got the results yet on Zika. But there is limited but very worrying real data that suggests that these cases are related to Zika. So there were 2 cases early on which really set the alarm off, and why Brazil raised the alert was they found Zika virus by PCR in the amniotic fluid of kids who have abnormalities in the womb. There was a stillborn child with microcephaly who tested positive. The US CDC looked at tissues and samples from 4 children, 2 who were miscarried and 2 newborns that died shortly afterwards, and those 4 were positive for Zika virus. There's 6 cases reported in obstetrics gynecology, 1 in Hawaii, and another one where the placenta tested positive. So the temporal association, the increase, and the finding of the virus in the amniotic fluid and aborted fetuses and abnormal children, is, I think, very strong circumstantial evidence. Just quickly, one other additional complication is Guillain-Barré Syndrome. So we're also seeing this neurological complication, and this was noted in French Polynesia from the December 2013 outbreak. So this is it's a post-infectious syndrome that's due to peripheral nerve damage. People get pain and other abnormal sensations and weakness that starts peripherally and goes centrally. It can be very severe, so most patients ended up hospitalised, some on ventilators because they get respiratory muscle paralysis. It's thought to be an immunological response, so people get an infection and they have an immunological response that attacks the nerve cells, and generally occurs 2 to 4 weeks after infection. It's pretty horrible. Very few deaths if you've got good health care, but it takes a very long time to recover, and some people have residual deficits even years later. So there's been an association both in French Polynesia, the outbreak there, where they saw an increase in Guillain-Barré syndrome, and Brazil have now seen an increase in Guillain-Barré syndrome. So what are we doing? We've been involved through ISARIC, that's the International Severe Acute Respiratory and Emerging Infections Consortium, and the coordinating centre is here. And since November, ISARIC have been coordinating global teleconferences with WHO and other research partners about defining the research needs and trying to standardise responses. And through PREPARE, this is a European project that we're running some of the work packages of here. This is to do pan-European studies and clinical preparedness for emerging infections. We were already planning to do a study of arbovirus infections in the Balkan Peninsula starting this year. So we're going to have to expand that now to some of the other countries where Aedes albopictus is present, so expand it across to Spain and Italy so that this coming season we can detect if Zika virus is introduced and the level of the problem. So there's a number of areas where research is needed. So there's still a big need for underpinning research. The diagnostics are difficult. The PCR is okay, but the serology is very difficult because it cross-reacts with other flaviviruses. And there's a need for standardised reagents to do quality assurance, standardised positive serology and antigens, etc. There isn't yet a good animal model, which we would need for looking at the pathogenesis and interventions. And there's a need for data standards. I told you about the difficulty with the definitions for microcephaly, but there's all sorts of other definitions we would want to use to standardise looking at the epidemiology and the outcomes, and that's not been done yet. Epidemiological research, really, we just don't know the attributable risk of the birth defects. We know there's an association, we believe it to be causal, we don't yet know the magnitude. What's the absolute risk for women living in that area of getting infected and then it affecting the fetus? Same with Guillain-Barré syndrome. Work is needed on vector biology. We don't know how competent a vector Aedes albopictuses or other mosquitoes. There's a need for clinical research, looking at the different clinical phenotypes and the natural history. What are the risk factors and cofactors for congenital abnormalities? I mean, particularly, it may be that it's not just Zika virus, it may be Zika virus plus something during the pregnancy that results in a high risk of a birth defect. We don't know, perhaps even a co-infection. And the process of pathogenesis. And finally, interventions. Currently, there's vector control, which is difficult for these very fit mosquitoes, very widespread mosquitoes. There's currently no therapeutics, but people are screening small molecules to see if any of those might work. But experience with dengue suggests that's probably not, well, it's going to be difficult. And the same with vaccines. Vaccines are being developed, and I know that Avian Hills Group's looking at developing vaccines, but I think we're at a very early stage, and it may be quite some time before a vaccine's around. So thank you very much.